I'm Dr. Eduardo Salvati. I'm the Director Emeritus of the Hip and Knee Service at the Hospital for Special Surgery and Clinical Professor of Orthopedic Surgery at the Weill Medical College of Cornell University, New York. In this video, we will present with Dr. Alejandro Gonzalez de la Valle our routine preoperative planning of a hybrid total hip replacement. The preoperative template is an essential part of the preoperative planning. They include simple measurements following the surgical steps that allow the OR nurse and the surgical team to know in advance the components to be implanted. It's a technique that has been perfected during the last 4 decades. The surgical goal is to re-establish the normal hip biomechanics, correct component position, solid fixation, equalization of leg length, avoid impingement to result in a stable total hip in extreme ranges of motion. Our preoperative imaging includes a true AP of both hips, AP standing of both knees, as frequently the hip pain will radiate to the knee, an AP and lateral of the lumbosacral spine. If you are confronted in the operating room with a pelvic tilt without available x-rays of the lumbosacral spine, you will not be able to determine whether the pelvic tilt is secondary to a severely adducted right hip or to a lumbosacral pathology. Likewise, if you don't have a lateral view of the lumbosacral spine, you can't assess lordosis, kyphosis, mobility, and all factors which could influence the position of the acetabular component. Such information is essential to do an adequate preoperative planning. I prefer to use acetate templates to define the size of the cup and its center of rotation. The preoperative templating starts with the acetabular cup, placing a dot on the lateral wall of the teardrop, another on the superolateral margin of the acetabulum, and a third one on the superomedial dome. The size of the cup is recorded on an adhesive tape placed beside the X-ray. We then proceed to define the new center of the prosthetic head, compensating for any leg length discrepancy based on the clinical and X-ray findings. On the AP radiograph, the horizontal line should be parallel to the bottom of the teardrops. The clinical leg length discrepancy is based on the patient's subjective perception of being even with a block under the shorter foot. I find it useful to triple check the clinical and radiographic measurements in the holding area while the patient is lying down supine, straight, assessing the heel level with the ankles dorsiflexed. For the femoral template, we overlap the femoral template of the proper size to allow preservation of cancellous bone for cement interdigitation. It is placed parallel to the long axis of the femur and well centered in the intramedullary canal, placing the center of rotation on the dot, which compensates for the leg length discrepancy. The location of the femoral neck cut is marked as well as the location of the distal centralizer. In this case, a 13 versus heritage extended stem is selected and marked on the adhesive tape. The distance from the superior corner of the lesser trochanter to the neck cut is measured, as well as the distance to the new center of the prosthetic head, LTC, and included on the adhesive tape. The diameter of the intramedullary canal is measured to select the size of the distal centralizer and cement restrictor. We also measure the valgus varus position of the stem at the level of the femoral cut and record that distance within a circle. We select the diameter of the femoral head depending on age and cup diameter, allowing for a thicker polyethylene for the younger patient for increased longevity and a larger head in the older patient to provide more stability by increasing head-neck ratio and reduce the risk of dislocation. The adhesive tape is placed on the enclosure panel opposite to the surgeon. We publish this technique in detail in the Journal of Arthroplasty and in the Journal of the American Academy of Orthopedic Surgeons in 2005. In 2008, we did a prospective study comparing acetate and digital templating and found that acetate templating was more accurate in our hands. Similar findings were published by Petretta et al. In 2015. Over the years, there has been a shift towards digital templating, but I still find acetate templating more accurate. As residents and fellows are using digital templating, I like to compare their measurements with mine. In general, we are in agreement with those of the fellows and find discrepancies with those of the less experienced residents. Once scrubbed and prior to enter to the surgical enclosure, I routinely stop to analyze the X-ray in detail to keep the image in memory, which helps while doing the surgery.